Good evening everyone and welcome to this webinar on screening. Let me start by first saying that no, I have not come here in a boat or in a helicopter or something like that, and it's because the waters have dried up and Kerala is coming back to normalcy, and one of the main reasons why I could not join you with this webinar last week was because we were having a natural disaster which probably was the biggest in terms of the natural disasters that have ever been faced in Kerala. Now, having said that, let's go to our presentation and talk about screening and what numbers mean. Most of the time when we talk about screening, we always take the report, let it be a combined test screening report or an ultrasound screening report, and we look at the report and then say, okay, it is screen positive, screen negative, and the story ends there. But before we understand what is screen positive or what is screen negative, we should understand what all these numbers mean, and that is the basic purpose of this talk, to tell you what these numbers mean and to understand that screening is not just screen positive or screen negative. It is much more than that. And before we go into that, we should understand what is our responsibility. Our responsibility is not to find out babies with Down syndrome and terminate them. That is not our responsibility. Our responsibility is to give the mother the accurate assessment of the risk. What is the risk of having a baby with Down syndrome? What is the risk of having a miscarriage while trying to find out if your baby is having Down syndrome? And do they actually need a baby with Down syndrome or not? These are things that neither you or I can actually assess. These are things that the mother needs to decide for herself. And therefore, our responsibility is not to screen and find out who is screen positive or screen negative, but our responsibility is to give the correct information to the mother and allow them to make the decision based on their choices. And that is why this editorial, which came out in 1994, is especially useful, because this editorial actually looks at screening from the mother's perspective, from the patient's perspective, and that's what we should all be doing. The primary question is, why do we need to screen? Why do we need to screen for Downs at all? Because if you look at pregnancies in general, 1 in 300 of them are going to be affected with chromosomal abnormalities. 95% of those abnormalities are going to be trisomy 18, 13 or 21. And a majority of those abnormalities are going to be trisomy 21. And the biggest problem here is that more than 90% of these affected children are going to be born to mothers that are young. And that is why it is important to screen for Down syndrome. Now, if you say that Down syndrome is such a huge problem, then why not do a diagnostic test for all? Why don't we just stick in the needle into all pregnant women and try to find out if each of these babies are normal or abnormal? Now, the problem here is that the diagnostic test carries the risk of having a baby with Down syndrome, would have the risk of having abortion. So, if you have an inherent risk of abortion, say around 1%, it means that for every 4 babies with Down syndrome that you pick up, you will lose 1 normal child, and losing a normal child is totally unacceptable, and that is why you need to have screening. Now, there are a number of tests available, and how do you decide which test is the best test? And for that, you need to understand 3 important variables. The first one is what I call the detection rate. Now, detection rate means how many abnormal babies can your test pick up. For example, let's say there are around 100 babies with Down syndrome that are going to be born in India or in the state of Kerala. And if your test can pick up 95% of the 95 babies out of those 100, it means the detection rate of your test is 95%. That means if you are able to pick up 95 out of 100, the detection rate is 95%. The second important thing you have to understand is the false positive rate, which means how many normal babies would be coming under the bracket of having increased risk, but when an amniocentesis is done, they would be normal. So, these are the normal babies who are going to have an unnecessary amniocentesis. Now, when you do an unnecessary amniocentesis on a normal fetus, you are increasing the risk of abortion for that normal fetus, and therefore you would want a test that has the least false positive rate. Now, when you talk about false positive rate, you should understand that that false positive rate is based on the general population. For example, let us take into consideration that there are 5 lakh pregnant women in the state of Kerala, and you have a test that has a false positive rate of around 5%. So that means around 2,500 women would have an unnecessary amniocentesis, and that is unacceptable. And therefore, you would not want to have a very high false positive rate, because these women would have an unnecessary amniocentesis which would lead to abortion. Therefore, you need a test that has a high detection rate and a low false positive rate. The third important point is the positive predictive value. For example, you have a test and you find that the test result is positive. The next thing the mother is going to ask you is, what are the chances that I will have an abnormal child because this result is positive? So here what we want to know is, what are the chances of having an abnormal child once a screening test becomes positive? It is also called as OAPR. I'll be talking about that a bit more in detail later on. Now, these 3 important points should be kept in mind while you're trying to assess whether a screening test is good or bad. Now, let us look at the age-old screening test that has been employed, maternal age. If you decide to screen all mothers based on maternal age, what is going to happen is that you're going to detect only 30% of your Down syndrome babies. So the detection rate is going to be very dismal, and therefore you cannot use maternal age as a screening tool, because as I told you before, majority of your Down syndrome babies are going to be born in the younger age group. But still, maternal age is useful because it gives you the a priori risk or the background risk. Now, if you look at screening, there are a number of modalities available, like serum screening, ultrasound screening, combinations of these, and also NIPT. And we are going to look at these one by one and look at what these numbers mean. Let us start off with serum screening. Now, in serum screening, we have principally 3 common tests that are usually used: the dual test, the triple test, and the quadruple test. The dual test being a combination of beta HCG and PAPA, the triple test being a combination of beta HCG, AFP, and estradiol, and the quadruple test having the added product inhibin A. We do not use the triple test anymore because it is has a less detection rate, and therefore now we stick to the dual test and the quadruple test. Now, before we go into understanding what these screening tests actually mean, we should understand a bit about statistics. Now, don't roll up your eyes as yet. I know statistics is something that we as medical professionals do not like, but I want you to just be with me as I take you through these basic statistic principles. The first thing you have to understand is what is known as a normal distribution, a Gaussian curve, or a Bell's curve. And along with that, you should understand what is the meaning of multiples of median. Now, this is what a Bell's curve or a Gaussian distribution curve looks like. Now, if you look at any biological variable, let it be height, weight, or blood pressure, any biological variable, a biological variable that is present in all individuals, what you're going to find is that there is going to be a cluster of people that are going to have a value that is closer to the average. And that is what you're seeing here, the average. For example, if you take height, you would say that maybe the average height of the Indian male is around, say, 5 feet 5 or 5 feet 6, and you would find that most of the men and women would fall within that group. But in spite of that, there would be a few who would be very tall but still would be normal, and also would be short and still would be normal. But as you move away from that middle line, you're going to see that the chance of them being normal decreases on either side, whether it is more or less. So when you have a person who is greater than 2 standard deviations to that mean, it is greater than 2 moms, and when it is less than 2 standard deviations, it is 0.5 moms. So when you look at moms, and if you know that it is greater than 2, it means that it is greater than 2 times the average value, therefore it can be abnormal. And the same thing when it is less. When it is less than 0.5 moms, it is less than 2 standard deviations than the average, and therefore there is a possibility that it can be abnormal. Now, keeping this in mind, let us look at the products that we are trying to assess. We are looking at products which can be largely classified into placental products or fetal products. Now, placental products are beta HCG, PAPA, and inhibin A, and fetal products would be MSAFP and estradiol. Now, if you look at the normal distribution in normal fetuses and Down syndrome babies, Now this distribution, the red line is the distribution of beta HCG in Down's babies, and the blue line is the distribution of beta HCG in normal fetuses. Now by looking at this, what do you understand? Immediately you know that beta HCG has a median value that is more than that of the normal fetuses. And if you look at PAP-A, what do you find? You find that the graph has moved towards the left. So the average value is lesser than the average value that you would find in normal fetuses. So by looking at this graph, you know that the distribution of these products is different in Down syndrome babies and normal fetuses. Now let us look at the other markers. Same thing here. You look at AFP, it is less in Downs, inhibin A is more in Downs, estradiol is less, and HCG is more. So by looking at this, some sort of a pattern comes to you. What pattern is visible here? You can see that some products are more in Down syndrome babies while some products are less. And if you look at them closely, something exciting really comes up. The most important point here is that none of these products are produced on chromosome 21. None of these placental products or fetal products are produced on chromosome 21. But when you have a baby with an aneuploidy like chromosome 21, the fetal synthesis decreases, and therefore what happens is that the fetal products are found to be less. You can see that estradiol is less, AFP is less, and here what happens is the placenta overcompensate, and therefore the placenta tries to produce a hyper response and produces more amount of inhibin, more amount of beta HCG, and that is what is called as the trisomy 21 profile. Here you have decreased fetal products and you have increased placental products. Now in other aneuploidies like say trisomy 18 or trisomy 13 or triploidies, digyneic triploidies, just the opposite happens. In fact, you have decreased placental products as well as decreased fetal products. So you have a combination of both, and this is what is called as trisomy 18 profile of poor placental function. So here you will find that the curves are all towards the left. Beta HCG, inhibin A, everything is less because the placental as well as the fetal function is going to be poor. And here also you have to remember that the Down syndrome profile that you see, that is increased placental products and decreased fetal products, can occur in other aneuploidies as well, like diandric triploidies or Turner's with hydrops. And that is why screening is so important, because when you screen, you are not only picking up Down syndrome, but you are also picking up a lot of other aneuploidies. In fact, 78% of the other significant aneuploidies you can pick up if you do a good serum screening test. So how do you use serum screening test? You can use the combined test, the quadruple test, or you can use a combination of them as a serum integrated test, stepwise sequential screening or contingent screening. I will not go into the details of all these, but I'll just brush upon these topics so that you can understand what to expect from these various tests. Let's start off with the combined test. Now the combined test, as the name suggests, is a combination of NT, the markers beta HCG PAP-A, and the maternal characteristics. Now the cornerstone for a good combined test is to have a good NT. And I don't have actually because of shortage of time, I will not be able to tell you how to take a good NT, but you should take a good NT if you need to have a good combined test, and these are the things that you would look for. As you can see on your screen, this is how a good NT image should look like if this test has to have any value. And after the NT, the next thing that you look at is the maternal age, and here there is a very important point that I want to stress. When you look at the risk of a mother, there are two things that are involved here: the maternal age and the gestational age. As the maternal age increases, the risk of having a baby with aneuploidy increases, but at the same time, as the gestational age increases, the risk of having a baby with aneuploidy decreases. Now look at this table. You can see here that a 40-year-old lady at 12 weeks, her risk is around 1 in 160 to have a baby with trisomy 18, but as she goes closer to term, the risk drops to around 1 in 1150. Now why is that important to us as clinicians? It is important to us because if suppose a mother comes into you, she is 41 years old, she has not done any screening, but she has come to you at say around 28 or 29 weeks. What do you do at that point of time? 9 times of out of 10 you would do a scan and then you would scare the hell out of her, telling her that she has a high risk of having a baby with Down syndrome. Why didn't you get a screening done? Why didn't you do a screening done? Your gynecologist did not do the right thing by not doing a screening. That is not how you would counsel her. You would counsel her that yes, there is an increased risk, but as your gestational age has progressed to 28 weeks, and because this baby is not showing any other signs or markers for Down syndrome, the chance that she will have a baby with Down syndrome or aneuploidy is actually significantly less. And therefore, that would actually mean a lot to that patient, rather than telling that patient that there is a huge risk that they are going to have a baby with Down syndrome or aneuploidy. So, higher the gestational age is actually something that works in favor of the mother in not having a baby with Down syndrome. The nuchal translucency, as is obvious, as it increases, the risk of having a baby with Down syndrome increases, and then you add in the maternal characteristics. And finally, after you get the result of the combined test, you can think of adding other markers. And here again, there are a number of other markers that you can look at. You can look at the nasal bone, you can look at its presence or absence, which increases the risk. You can look at the ductus venosus, you can look for reversal of the ductus venosus, which increases the risk for Down syndrome, or you can look for tricuspid regurgitation, which increases the risk for Down syndrome. And especially tricuspid regurgitation is useful because it looks at a congenital heart disease, which is very common in Down syndrome, like AV canal defect. Now you can see that I have not spent a lot of time talking about these markers. Now why I have not spent so much time on talking about these markers is because it doesn't matter how many markers you have. It doesn't matter if you look at n number of markers, you can never make a screening test a diagnostic test. So if you have a test that is having a sensitivity of around 95% or 96% and you add in all your markers, you would probably increase your sensitivity by 1% maximum, or maybe 2% if you are looking at all the other markers. But so the question is, do you have enough people to train to actually look at these properly? Because if you don't look at these markers properly, there is a good chance that you could do more harm than good. So the best part would be to stick to a good combined test and think of 1 or 2 markers that you can do confidently, or train your sonologist to do confidently, and then think about adding them all into your combined test. Now that was the background on what a combined test means. And now coming to actually reading a report. You have a report of a combined test in front of you, and how would you interpret that report? Now let us look at this report. Now by looking at this report, what do most of us do? 9 out of 10 times you would see that red bar, you would say, okay, screen positive, send this patient for amniocentesis, and the story ends there. But that is not how you would approach a screening test when you look at the result. Now I agree that the red bar tells you that it is screen positive. But just let us look at what is happening here. This lady had an a priori risk of around 1 in 1000 based on her age. Now after you did your screening, her risk has jumped to 1 in 220, and which is above the cutoff of 1 in 250. So you have a woman who has become high risk after your combined test. Now let us look at all these variables and see what is happening here. Let us look at the serum markers first. What is happening to PAPE? PAPE is less, but is it less than 0.5 moms? It is not. It is still within the normal range. Look at beta HCG. Is it very high? It is not. It is still close to 1. It is not very high. So does this fit the trisomy 21 profile? The trisomy 21 profile would be increased placental products and decreased fetal products, but that is not what is happening here. Both these things look close to 1 within the normal range. So why is the screen test positive? This is positive because the NT is high. The NT is greater than 2.12 moms for that particular gestation, and therefore for this test to have any value, the NT has to be perfect. And that's why the first thing that you would do when you look at this screening test is to ask for an NT image. You look for the NT image, and if the NT image is proper, then it makes sense that this is actually a screening test that has turned out to be positive. If not, then this screening test has got no value. Now let's look at another case. Now here again, when you are screening, here you can see that there are 2 red bars here. The first red bar tells you the background risk of this mother. The background risk is around 1 in 65. Now after you have done the combined test, it has increased to around 1 in 40. Now when you know that the risk is 1 in 65 when this mother starts, it is obvious that this mother's age is going to be high. She is an old woman, she is 42 years old, she is an elderly gravida, and that is why she has got a prior risk that is high. Now here again the concept is to understand why this report has become positive. The NT value looks normal, it is around 1.13, it is close to 1 mom. The beta HCG also looks okay, but it is the PAPA that has actually gone very low. The PAPA is less than 0.5 moms, and that is the reason why the screening test has become positive. And why is it important for us to look at this report? It is important because it tells us two things. One, yes, there is an increased risk for Down syndrome, but it also tells us that because the PAPA is low, there is a chance that this mother may develop preeclampsia or this fetus may develop growth restriction later on, and therefore this screening report is not only telling us about Down syndrome, but it is also telling about the maternal condition that this mother may develop, and also the possibility that there could be growth restriction. Now in certain conditions you are not going to do screening, and the most important condition is when you have an NT that is greater than the 99 centile, that is around 3.5 moms. Now when you have an NT that is so high, you know that the chance of having a chromosomal abnormality is high, and therefore when the NT is greater than 3.5, it is good to go in for direct invasive testing and try to find out if the baby is normal or not. Now having said that, increased NT does not only mean chromosomal defects. You have to think of cardiac, skeletal, genetic disorders and fetal infections, and once you have ruled all that out, there is a less than 1% chance that this baby will have a problem. But if you don't, even then there is a chance of a normal fetus around 70% of the time. So if you have an increased NT greater than 3.5 moms, do not think of screening. Now coming to the next test, the quadruple test. Now this is a combination of beta HCG, AFP, estradiol and inhibin, and it's usually done after 16 weeks, and normally we do it when we are not able to do the first trimester screening test. For example, they come in late, they are booked late, and that is when we would think of doing a quadruple test, or if they want to do it as an add-on test for the serum integrated testing or stepwise sequential screening or contingent screening. Now I will just tell you what these tests are very briefly. Now when you do an integrated test, what you are actually doing is you are integrating two tests, the combined test and the quadruple test. You are first doing the combined test and you are not telling the result to anyone, and then again the patient is called back and you are doing a second trimester quadruple test and then giving the final risk after you integrate both the combined test and the quadruple test. Now the basic problem here is that it is very difficult to get a patient to come back again to do a second screening, and also it is difficult to integrate these tests and give a screening result in the second trimester, and as all of you know, our termination window closes at around 20 weeks, and therefore doing a second trimester screening is not going to work for us. The stepwise sequential is slightly different in the sense that you would do a combined test and then you would divide these women into two groups, low risk group and a high risk group. The low risk group are then having another test like a quadruple test in the second trimester, which is integrated with the combined test, and here again depending upon the final risk you would decide whether you want to send this patient home or do an invasive testing. And if it comes out to have a high risk after the initial combined test, you would directly go in for invasive testing. Here again the problem is that these low risk women will have to come back again, do a quadruple test before they actually know whether they are low risk or not. The third and the most commonly used method is contingent screening. In contingent screening, we are using a first trimester test, the combined test, and dividing women into three groups: the low risk group, the high risk group and the intermediate group. The high risk women are then given an invasive test like CVS or amniocentesis. The low risk women are sent home, no further testing is done on them, and the intermediate group is then offered either a quadruple test which is integrated with the combined test, or you can do a genetic sonogram, or you can do an NIPT. Now the problem with doing a quadruple test in the second trimester is that you have to integrate it with the first trimester combined test, which is not always possible, and most of the labs don't do it, and you cannot do it as a standalone test. You have to integrate it. If you do not, then there is no value for it. Now after listening to all these tests, which is the best test? As I told you, there are two things that you look at: detection rate and false positive rate, and that is how you tell whether a test is good or bad. Now, one method is to fix the detection rate of all the tests that you want to study and see which test has the least false positive rate. So, the test that has the least false positive rate will be the best test. And if you look at this, you can see that the least false positive is for the fully integrated testing, followed by the combined test. Now, because this is a second trimester test and because it needs integration, we will not be doing it, and therefore the best test would be the combined test because it has got the least false positive rate. Now, having talked about the false positive rate, there are two things that affect the false positive rate apart from the quality of the test, and those two things can be directly influenced by you, and that is the cutoff and the gestational age. Now, if you look at how cutoff is related to the false positive rate, is that when you have a higher cutoff, for example, the cutoff that we normally use is 1 in 250. Any woman that has a risk of above 1 in 250, we classify as high risk and we do an amniocentesis to find out whether the baby has Down syndrome or not. But when we increase that cutoff to say 1 in 350, look what happens to the false positive rate, it increases. So, if you keep the false positive rate high, it means your detection rate is probably high, but at the same time it is because your cutoff is high. So, a lot of unnecessary amniocentesis will be done. So, your aim should be to have a decent enough cutoff so that your false positive rates do not go beyond 5%. The second most common reason why you have a high false positive rate is because you don't get the gestational age right. Whenever you are doing screening, if you go by the menstrual age, and you can see here the green dots are indicative of the menstrual age and the relative values of beta HCG, estradiol and AFP. Now, if you go by the menstrual age, you would see that HCG is high, estradiol is low, AFP is low. So, what does that point towards to? It points towards Down syndrome. But if you correct the gestational age and base your gestational age on the ultrasound measurement, then you would see that the HCG, estradiol and AFP are all normal, and therefore gestational age has to be extremely accurate if you want to decrease your false positive rate, and it is not just the quality of your test. Another method to compare tests is to fix the false positive rate and look at which has the highest detection rate, and here again the highest detection rate is for the integrated, followed by the combined test, and therefore we would always follow the combined test because we need a test that is effective in the first trimester. Now, coming to the most important point as far as patients are concerned, and this is what I talked about earlier, positive predictive value or OAPR, odds of having an affected child after a positive result, and this is what is very, very important. Now, a mother, when she comes into your OP with a screening test that is positive, let's say 1 in 200 or 1 in 300, the first thing that she is going to ask you is, doctor, what are the chances of my baby having Down syndrome? And normally what do? We start telling her that there is 1 in 250 chances that your baby is going to have Down syndrome. But that actually makes no sense to the patient. What she wants to know is what is the exact percentage or chance of having an abnormal result, abnormal baby once your screening test is positive, and that is what is OAPR. And if you look at the OAPR, there is 1 in 5 chance if you do an integrated test that the child will be abnormal if your result is screened positive, and look at the combined test. There is a 1 in 22 chance that if your combined test is positive, your baby is going to have Down syndrome. Let me put it differently. You need to have 22 results of combined tests that are positive before you actually pick up a case with Down syndrome. If you like percentages, an easy method to remember is that if you have a mother who comes into you with a combined test result that is positive, there is a 4% chance that her baby will be affected with Down syndrome. 96% of the time the child is going to be normal, and those are the numbers that are actually going to help the mother understand that, okay, this is my risk. I've got a 96% chance of having a normal child in spite of my combined test result being positive. So, which test would you use? I would definitely say the combined test, basically because it is an early test, because you have an early test in the first trimester that will allow you to decide whether this child has got a risk for aneuploidy or not. And if you can't do the combined test, or if you miss out on the combined test, the next option would be the quadruple test, especially for late bookers. Now coming to the second part of my talk, the genetic sonogram and the place of the genetic sonogram when you talk about screening. Now the first thing to understand is that the genetic sonogram is basically to look for soft markers, and these soft markers will tell you whether there is an increased risk of having a baby with Down syndrome or not. It is not a test to replace the combined test. The combined test is the best test, but the genetic sonogram acts as an added on test to your combined test. So basically what you are doing is you are looking at variations in normal anatomy, and you are trying to find out whether these markers will increase the risk of having a baby with Down syndrome. And this paper, this meta-analysis is something that all of you should read, because this is the paper that actually looks at these markers and gives you two important things. The first thing being the positive likelihood ratio, that is the chance that a baby will have Down syndrome if any of these markers are present, and the second thing is the negative likelihood ratio, that is the chance that this baby will not have Down syndrome if these markers are absent. So in likelihood ratio you have positive likelihood ratio and negative likelihood ratio. Chance that a baby will have Down syndrome if a marker is positive, and chance that the baby will not have Down syndrome if the marker is absent. Now to understand how a genetic sonogram works, you have to understand this basic mathematical concept which is called as the Bayes theorem. If you are not already asleep, I am sure this will put you to sleep, because this is a slightly difficult concept, but this is essential to understand what screening is from a genetic sonogram perspective. Now in Bayes theorem, there are three important factors happening. The first thing is a symptom or an abnormality that leads to an event. The second thing is the background risk, and the third thing is how common is that symptom in the general population versus the affected population. Let me make that very simple with the help of an example. Suppose you wake up in the morning with a headache. So you got up early one morning and you have a severe headache. Now the symptom here is headache, and now because of that headache you are worried you are going to have brain tumor. So that is the event. Now the symptom is the headache, and the second thing, the event, is brain tumor. Now when you have headache, you are worried you are going to have a brain tumor, you call up your friend, you call up the best neurologist, and you fix up an appointment for getting a CT scan done because you are worried you are having brain tumor. Now before you do that, the next thing that you have to ask yourself, before you go in for your CT scan, the next thing you have to ask yourself is, what is the background risk? What is my background risk of having brain tumor? I am 40 years old, I do not have any other problems, no family history. What are the chances that I am going to have brain tumor? It is not going to be that high. So that actually tells you that your background risk is not that high, which is also called as your a priori risk. And the third thing you have to ask is, how common is this symptom or this problem that you have, headache, when compared to normal population as well as the population that has brain tumor? You would find that it is a very common symptom. It is not something that stands out in women that have or men that have brain tumor. So therefore you understand that this is not a major problem. But on the other hand, if you had two symptoms, like if you had headache and diplopia, then the symptoms become stronger, and the chance that you could have the event, that is brain tumor, becomes slightly more higher. And the same thing happens with markers. If you have a marker, the first thing that you have to ask yourself is, what is the background risk of the mother for having Down syndrome? And the third thing that you would ask is, what are the chances that that marker is going to be more common in mothers having babies with Down syndrome as compared to normal fetuses? And then once you have that, you will know whether this marker is strong enough to warrant an invasive testing. So you will have the background risk, to which you would add the likelihood ratio, multiply it, you will get your final risk, and that will tell you whether you need to actually go in for invasive testing. Now having said that, there are a few markers like ventriculomegaly, aberrant right subclavian artery, or increased nuchal fold or absent nasal bone, which would warrant direct testing, because the chance that this symptom will occur in a baby with Down syndrome is much higher. Therefore the symptom event correlation is much higher in these particular markers, and therefore you may have to go in for direct testing. Now how do you do this? The same paper that I talked about gives you the positive likelihood ratio of every marker that is present and the negative likelihood ratio of every marker that is absent. So when you multiply the positive likelihood ratio of the present marker with the negative likelihood ratio of the absent marker, you would get your final risk. But that's too much mathematics and too much calculation. So instead of doing all that, you go back to the paper that I talked about, and they have got this Excel sheet that you can actually download, and it's a free download. And into that Excel sheet, you can add in the markers that are present and the markers that are absent. Now here I have added the marker that is present, which is the echogenic bowel, and all the other markers are absent, and it automatically calculates the likelihood ratio for that combination. Now if you have two markers being present, like echogenic bowel as well as an aberrant right subclavian artery, with all the other markers being absent, and you can see here that the likelihood ratio has been automatically calculated. So you don't have to do any kind of mathematical calculation, just download that Excel sheet, type in the markers that you see, and you will get your final likelihood ratio. Now that final likelihood ratio, you are going to take it and multiply it with the background risk of the mother. Now if the mother has done a screening test before coming to meet you, let it be a combined test or a quadruple test, then the final risk of that test would be your a priori risk. If she has not done any test before that, then you would use her maternal age and you would multiply it with the likelihood ratio and then give her the final risk. And if that final risk is coming high, you would go in for invasive testing. If it is low, you would probably not test her and send her home. Now that was the second part of the talk about genetic sonogram. Now I am coming to the last part of my talk, which deals with the new kid on the block, NIPT, non-invasive prenatal testing or non-invasive prenatal screening. Now this test, discovered in 1997, is supposed to be the most effective screening tool for trisomy 21. And I want you to remember what I told you in the beginning. How do you judge a test? You judge a test by looking at the detection rate and the false positive rate. Look at the detection rate of NIPT, 99%. Look at the false positive rate, 0.1%. Now these things are actually staring at you and telling you that this is probably the best test. But is that so, or is that actually just sales pitch? That's what I want all of you to understand here. NIPT is a good test, but it is not what it is made out to be. Now why I am telling you this is, the first and foremost thing that you should understand is that in NIPT we do not take the fetal DNA, separate it out and do a karyotype on the fetal DNA to see whether the baby is having Down syndrome. That is not what is being done. In layman's term, what you are actually doing here is you are assessing cell-free DNA of the mother, and this cell-free DNA is a collection of both maternal and fetal cells, and you cannot separate them. What you are actually doing is you are taking the maternal and fetal DNA and aligning them according to their respective chromosomes and seeing if there is an overrepresentation of a particular chromosome. And if there is an overrepresentation of a particular chromosome, say 21, you assume that the mother is normal and say that abnormality has come from the fetus, and that is how NIPT works. And yes, it is a good test, but there are certain limitations that you should be aware of. The first limitation is that 5% of the time you could not get a result. You can have a no result. The cost, of course, is still high, and it fails to pick up other aneuploidies like the rare aneuploidies. It fails to pick up those aneuploidies, and you would need to do an amniocentesis even if an NIPT is positive. But I am not going to go into all that. I just want you to concentrate on one point, the no result rate. Now why is it that when you do an NIPT, such a good test, you get no result? Now that could be because you have reduced fetal fraction, or you could have assay failure, or you could have sampling or a transport error. Now assay failure or transport error can be corrected, but the biggest problem is fetal fraction. So if you have an NIPT test with low fetal fraction, that is less than 4%. Now fetal fraction is the percentage of fetal DNA that is circulating in the mother's blood. If that is less than 4%, then the detection rate of that test drops from 99% to 70%, which means the detection rate of that test is now equal to that of your triple test. So you have a low fetal fraction that is changing a good test into a bad test, and therefore you should know why you have low fetal fraction. There are a couple of reasons why you have that. Like if you do it very early, less than 10 weeks, because there is less amount of circulating fetal DNA, then you can have low fetal fraction. But the two most important factors that you should remember is obesity and abnormal fetal karyotype. Now, in an obese mother, what happens is that her own normal DNA, cell-free DNA, is going to be extremely high within the blood of the mother, and therefore this high maternal DNA is going to drown out the cell-free fetal DNA, and therefore the fetal fraction is going to drop. And therefore, in an obese mother, if you try to do a repeat sampling, again you could get low fetal fraction, and therefore in obese women you would probably not get a result, and that is something you should be very aware of. So, if you have an obese woman who comes in and you want to do an NIPT, think again, because there is a good chance with higher BMI you would probably not get a result. The second most worrying factor of low fetal fraction is when you have an abnormal fetal karyotype. If you remember what I told you before, there is something called as trisomy 18 profile. Now, here the placenta and the fetus both are abnormal. So, here the placental products and the fetal products are going to be less, and because of that the circulating cell-free DNA is also going to be less, in turn meaning that the fetal fraction is going to be less, and therefore you are going to get a no result. And this is particularly worrying, because when you get no result, you are worried, is this because of the trisomy 18 profile phenomena? Is this because the baby is having some aneuploidy that we cannot pick up? And that is why when you get a no result with low fetal fraction, it should be worrying. Now, coming to the initial part that we talked about a detection rate of 99%. Now, I am just giving you an example to tell you that that is not true. For example, if you have 1 lakh women who go in for screening with NIPT, let us assume that out of that 1 lakh women, 200 babies are going to have trisomy 21. And if you have a 3% failure rate, the actual failure rate in real life scenarios would be around 5%. Now, let us take a conservative estimate of 3%. This means that 3000 euploid fetuses would get no result, and 6 trisomy 21 fetuses would not be picked up or have a no result, which means you would be picking up only 192 Down syndrome babies out of 200, and therefore your detection rate or your real screening performance would be just 96%, which is almost similar to that of a combined test with your markers thrown in. So, that is what you have to understand. The real performance of a screening test should take into account all these factors, that there could be the possibility of a no result. So, when you have low fetal fraction and you have no result on NIPT, what are the options available to us? We can go in for a repeat NIPT, but then you already know if the karyotype is abnormal or if the mother is obese, you would still not get a result. You can then go in for invasive testing if you do not get if you get a no result on NIPT, but then what would happen? Your false positive rates would be very high. Think about all those 3000 euploid fetuses with no result on NIPT. If you start doing amniocentesis for them, your false positive rates would be much higher than the 0.1% that is being purported. And finally, if you decide to do a quadruple test because you cannot do an NIPT, you have a low detection rate as compared to the first trimester combined test. So, the best method to use NIPT would be to do a combined test and then decide whether you want to do an NIPT or not based on your combined test. And if you get a no result on your NIPT, then you have the option of repeating the NIPT or the other things, but at least you have the combined test result, and you have the combined test result to fall back on and then decide whether you want to do an invasive test or go in for a genetic sonogram. And again, it is important to understand that in NIPT we are actually testing cell-free DNA that is derived from the placenta. So, there could be conditions where the placenta is abnormal and the fetus is normal, and it could also happen the other way around, that is the placenta is normal and the fetus is abnormal. And therefore, whenever you have a positive test on NIPT, you have to always go in for an amniocentesis. And you cannot do NIPT if your NT is greater than 3.5 or if there is structural abnormalities, because 8% of the time there would be initial abnormalities that could be picked up on karyotype or on array. So, what does that mean? So, does that mean that we cannot use the NIPT, or does that mean that you have to always use the combined test? For this, I always fall back onto this slide, which is particularly useful. And if you look at this slide, I want you to look at these numbers. the negative predictive value. Now, let me give you an example to just make you understand this. You have two women, both 25 years age. One has done an NIPT and the other one has done a combined test. Both have come as screen negative. And the person who has done the combined test is coming to you and asking you, doctor, I have done the combined test. My friend sitting outside has done the NIPT. Now, she has got a negative result. I have got a negative result. And she has spent 35,000 for her test. I have spent 2,500. Now, does that mean that my baby is having a lesser test compared to my friend sitting outside? Now, here I want all of you to remember these numbers. The negative predictive value of both NIPT and the combined test is the same, greater than 99.99%, because the negative predictive value depends upon the prevalence of the disease. So, if you have a good combined test, then and if it turns out to be negative, the chance that that baby will have Down syndrome is very, very less, similar to that of an NIPT, and therefore it does not mean that you have to always do a combined test or an NIPT following a combined test if the combined test comes out to be negative. So, how do we use NIPT? Now, the option that has already been discussed is to use NIPT for all, and as I have already shown you, that cannot be done basically because you miss out on other aneuploidies, and when you have no result, you are stuck. What do? You go ahead and do an invasive test and increase the false positive rate, or then you do an inferior test. So, you cannot do NIPT for all because of these arguments against them. So, what we would suggest and what we do at our center is that we do a combined test and we do a sort of a contingent screening. We divide women into 3 risk groups. One risk group being the 1 in 100 group, which are the high risk group, and in this group we go in for invasive testing. The reason why we do invasive testing in this group is that, as I told you, there are other abnormalities that can be picked up with the combined test, like Turner's, or it could be triploides, which cannot be picked up on NIPT, and this group will need an invasive test. The ones that come as low risk, that is greater than 1 in 2,500, that group will not require any testing and you can send them back home, because the chance that they would have Down syndrome is extremely unlikely. But in this group, that is between 1 in 100 to 1 in 2,500, you have the option of going in for NIPT, and this is only for the sole purpose of increasing your detection rate without increasing your false positive rate. Now, the cutoff is very important, as I told you. If you use a cutoff of around 1 in 250 and employ the same system, it will not bring a decrease in your false positive rate. Your invasive tests are still going to be high, and therefore, you should bring the cutoff down to 1 in 100 and thereby decrease your false positive rate and use the NIPT in such a way that you do not increase your invasive test rates. So, our take here would be that do a combined test and do a 12-week scan because they are indispensable, and use a contingent model and use NIPT only for the intermediate risk group. I hope after that exhausting session I have been able to bring about some sort of simplicity to all that confusion. Thank you for listening. If there are any questions, you can send them by mail or you can send it in the link below. Okay, I have got a few questions here. Let me just. Okay, this is the question on how does high drops alter serum markers in Turner's. Well, actually that is something that has not been studied very clearly, but it is true that there is this difference in placental function when there is high drops and when there is no high drops, and that is why they have different profiles when it comes to the serum markers. Okay, the intermediate risk group, how do you counsel them? Now, here again, see, the intermediate risk group, it depends on how do you classify them. You could classify them as 1 in 100 to 1 in 2,500 as I have told here, or you can use a system of 1 in 250 to 1 in 1000 depending upon what cutoffs you use. but essentially the chance that you would have a baby with Down syndrome in that group is not going to be that high, and therefore it is not actually necessary to do an invasive test. An NIPT would be the best option in the intermediate group if the patient is willing to do that, and otherwise you can always tell them that the risk is extremely low. And let me see what the other questions are. If the patient does not have any constraint of money and wants final and best answer for screening for trisomy 21, should we advise her directly NIPT only? Now here the problem, as I told you, is that NIPT would be able to give you a result for trisomy 21 and it is probably the best test. But if you get a no result on NIPT, which can happen, you are stuck with this problem. Why did I get a no result on NIPT? Did I get a no result because of low fetal fraction or something that can be corrected, or did I get a no result because of poor placental function? Now, if I get a no result because of poor placental function secondary to aneuploidy, I would have to go in and put in a needle and find out whether this baby is normal or abnormal. Now, if I do NIPT for all these women, there is a good chance that I would end up doing an unnecessary invasive test, and therefore it is always useful to have a combined test result that is there, and then to base your NIPT based on the findings that you get out of your combined test. Okay, this is a good question. What is your method of management when your post-test risk is higher than the age risk, but still the post-test risk is above the cutoff? And that is why it's important to look at why the test has become positive. It does not change. For example, if the mother's risk is say 1 in 700 or 1 in 1000, and you did your combined test and the risk came down to increased to 1 in 700. So 1 in 1000 has become now 1 in 700. Now you are worried, why did the test become from 1 in 1000 to 1 in 700? So is there an increased risk? You will not change your plan based on how the screening has behaved after, like a pre or post test. You are going to finally make your decision based on your final risk. You are not going to think about the prior risk or the posterior risk, because as I showed you in that case where the mother was around 42 years old, her risk has actually increased, but her risk has increased because of a bad PAPE, but her beta HCG was completely normal. So it could be because the fetus can have IUGR later on, or it could be because the NT was taken badly or something like that. So you would always act based on your final risk. A risk increase but still above the cutoff does not change your management at all. Okay, then how do you counsel and manage first trimester combined test report with low risk but beta HCG is above 2.5 moms? Again, it does not matter based on one single parameter. You are going to use a combination of factors, because let me give you another example. If you have an NT that is say 3.1 and you decide to go in for a screening test and your screening test comes out as negative, that does not mean that the baby has Down syndrome. It means your screening test is negative and you use the final risk that comes out of that screening test and decide your management based on that. You are not going to take individual parameters. You are going to use a combination of all these parameters to decide on what sort of management you would want to do. I guess that's all. Okay, what is the stand of serum markers in cases of pre-implantation genetic screening in assisted reproduction cases? Now, if you are doing PGS and you have embryos that have been pre-selected, and then you are going in for implantation. Now there again you can go for the same combined test that you want to do, unless you are doing PGS for a particular indication. For example, if you are doing pre-implantation genetic screening because the mother is or the father is a translocation carrier, you can do PGS, but you would still have to follow up and do an invasive test to confirm whether the child is normal or abnormal. There you cannot go in for screening because the background risk is very high. So you do PGS, you select the embryos, you put it back in, and in spite of that you would still have to do a CVS to confirm whether the child is normal or abnormal. is there any relation of sensitivity of the test with increased maternal age? No, the sensitivity of the test, as I told you, is the ability of the test to pick up Down syndrome. If there are 100 Down syndrome babies being born, if the test can pick up 95 of them, then that means the detection rate is 95%, the sensitivity is high. It is not related to the maternal age. Which test would you advise for an obstetrician where money is a problem? Okay, that's a difficult one. I think the combined test is the best test. There is no doubt on that, because you are just limiting yourself to 2 markers and you are doing an NT scan, and that helps because you are doing a number of things in a single test, but then it depends on how much money is available. The second best option would definitely be the quadruple test, but then again the quadruple test you would have to do it in the second trimester, and by doing that you would get the diagnosis pretty late. But the quadruple test you don't have to do the NT scan, which is also pretty expensive, but then you can't do without the 12-week scan. So the cost part is something that is very difficult to answer. If in addition of NB or DV in the intermediate risk group, giving low risk group, is it correct method always? I am not sure I understood that, but I think the question is, if you are in the intermediate risk group and these markers are positive, like an absent NB or a DV reversal. Now if you are in the intermediate risk group, say let us say 1 in 700 or 1 in 300 or something like that, and if you find that these markers are positive, like an absent NB or a DV reversal, then she automatically goes into the high risk group, that is lesser than 1 in 100. So when she is greater than 1 in 100, in that group you would definitely have to go in for invasive testing. So if any of these markers are present, the chance of having a baby with Down syndrome significantly increases, and there definitely invasive testing is warranted. I guess that's all. If there are any more questions. I guess that's all, and thank you for joining. If there are any more questions, you can send it by mail and I would be happy to answer them. Thank you.